This FedGov Today program is sponsored by SAS and Carasoft. On this edition of FedGov Today with Francis Rose, the Department of Veterans Affairs takes a pledge to share data, the secrets to operationalizing your agency's tools, and the digital modernization path ahead for the Defense Health Agency. The Director of DHA, Lieutenant General Talita Crossland, is here. Welcome to FedGov Today with Francis Rose. The Department of Veterans Affairs is taking a pledge to share data with 13 community health systems. Veterans can opt in to have their data available when they receive care at any of those care points. Dr. Shereef Elnahal is Undersecretary for Health at VA at HIMSS 2024 in Orlando this week. I asked him to define interoperability and what it means to veterans who get care from the VHA.
Well, it's pretty simple to us. When interoperability works, then patients, in our case veterans, have full control over where their healthcare information goes and have that control almost instantaneously. In other words, veteran can consent to a health system transacting with a different health system to make sure their information gets to the provider in front of them right then and there. And that's what we're trying to do with our interoperability pledge across 13 health systems, hoping to expand that list after this conference and beyond. And we are essentially a group of health systems agreeing to share veteran data with their consent in a way that allows for better coordination of care. By the way, an opportunity for our partner health systems to identify veterans at the point of care when they may not have known that they're treating a veteran, which is just really important information clinically, but also something that I think a lot of veterans would appreciate, knowing that their healthcare providers know that they have served.
What have you needed to do inside VHA, and what have these organizations that are outside VHA had to do to prepare for that interoperability goal?
It's actually quite easy to connect in with us. We have an open API system called Lighthouse. That's our platform in sharing information across veteran healthcare records. And so any health system can join by contacting us. And after that, you essentially turn on the functionality where they can query our veteran identifier API. Again, veterans have already consented on that. And their health information is sent and it pings that the health system is in front of a veteran. On top of that, we can push new policy, such as our policy to cover the costs of care for any veteran in acute suicidal crisis, no matter whether that veteran is enrolled in VA care or getting VA benefits, and no matter whether they're getting that care in the private sector or with us. And that's a new policy we announced last year that we can actually effectuate because we're helping these systems identify veterans in suicidal crisis. So push that information right then and there to have that instant information sharing to the benefit of veterans at the point of care.
What is involved in getting the permissions that are necessary to do that? What does the veteran have to consent to in order to be able to participate in this?
The veteran consents to having their health information in front of a clinician caring for them. And that's exactly how this is impacted. We don't send this information to administrators in these health systems. We send this information to folks at the point of care treating a veteran. So it's literally the doctor, the nurse, and the care team who are caring for that veteran. People who really should have access to all of the health information they need to give better care.
Yeah, what does the interoperability pledge itself consist of, Doctor?
It's a pledge to work with us to constantly innovate on use cases that help us meet veteran care needs across the country. Again, no matter whether a veteran is enrolled in healthcare with us or not. Foundation is health systems querying our veteran identifier database to understand who's a veteran and who isn't in their health system. And then on top of that, we can send information for veterans in suicidal crisis about the Compact Act. We can send information about the PACT Act, which, by the way, just last week effectuated healthcare eligibility for every post 9/11 veteran, every Gulf War veteran, and every veteran who's deployed in Vietnam to get healthcare for life with the VA, regardless of the health condition they have or whether that condition is connected to their service. So we just need to use this network of interoperable partners to get the word out about these new benefits to veterans as much as possible.
You have talked about a number of times in the past innovation, and you mentioned it in this conversation. We talked about artificial intelligence the last time that you and I spoke. How do you find the pockets of innovation that are happening either within the agency or in the private sector and get those into use cases inside the department and then scale them when appropriate?
So we have a really amazing part of our organization called the innovation ecosystem that constantly queries our frontline employees for solutions to our most important system-wide priorities. So veteran access to care, hiring faster and more competitively, and so on. And so when you have frontline employees who are as innovative and veteran-focused as we have in the VA, you often find solutions in every corner of our system that are working. The question is whether those solutions can scale and exactly what benefit that they're conferring to veterans. And so we have a system that helps lift that up. It's a system that's similar to Shark Tank, where literally medical centers bid resources, investment of resources to being able to implement best practices. So that's one way to do it. But we also try to source the best from the private sector. And our AI tech sprints are an example of that. We asked early stage companies and folks who are in the AI space to apply to us to help solve the clinician burnout problem. Things like ambient dictation, outside hospital record summaries, making those things more efficient so that our clinicians can spend more time seeing veterans and less time behind a computer terminal. And so we're looking for the best stuff inside and outside of the VA.
You shared with me an interesting anecdote before we went on the air about things that veterans tell you about what they observe in their own clinicians regarding burnout.
Veterans overwhelmingly tell me when I go across the country and do roundtables that once they get in front of our clinicians, they get excellent care. Our clinicians are compassionate, they know what they're doing, and they get veterans better. It's often the blocking and tackling before they get an appointment. So scheduling that appointment in the community if we don't offer the service directly within the VA. And then when they come in, a lot of them have told us that they think our clinicians are overworked. And sometimes our clinicians are visibly stressed, and that has an impact on veterans. They're concerned. And so that's why we're focusing on clinician burnout, because we know that our clinicians are telling us this, but also increasingly the veterans that we're serving.
You're using the concept of digital twins inside VHA to address that issue. It's one of the items that I talked about at your AI symposium last fall. What are the things that your clinicians tell you that you then can take action on to try to do things like that to help them address? How does that chain work inside VHA?
So we're really trying to get our use cases for AI directly from veterans and the employees who directly serve them. And so we do have some clinical use cases that are really promising. For example, technology that assists an endoscopist who's doing a colonoscopy to understand what the likelihood is of a polyp being malignant, or identifying a lesion in the first place that they may not have seen with the naked eye. And so we're implementing that across the system. Our GI specialists really think this is useful, and it has a direct impact on the quality of veteran care. Nobody wants to, of course, miss a concerning lesion on a colonoscopy that could turn into cancer. And so everything from some of the administrative work that we're doing to some of the clinical use cases directly speaks to a veteran benefit. And a lot of it is really just helping our frontline employees get the rote work done and spend more time in front of veterans.
Doctor, I want to go back to the interoperability pledge. As you roll that out, continue to deliver on it, how will you measure the success of that, whether it's achieving what you wanted to achieve or whether you need to redirect?
Success for me is real veteran benefit that's palpable, that veterans can see, touch, and feel. And one of our use cases to prevent veteran suicide is what I talked about before. We're flagging for health systems now, first Tufts, which has served over 1,000 veterans with this use case, to identify a veteran who came in for suicidal crisis. And that's an opportunity for their social workers to let them know that VA now has this policy where we will fully pay for that care. And by the way, after our announcement last week of massively expanded healthcare eligibility, that they can get free healthcare from the VA for life. And that's a really important thing for veterans to know, especially at a point of vulnerability at the point of care with our private sector partners. And so we've already benefited more than 1,000 veterans at Tufts alone. We have the ability to scale this across all Epic hospitals if they choose to turn the feature on. So we're talking about massive scale with this interoperable network in benefiting veterans and getting them help when they need it the most.
You can read more about the interoperability pledge and the other items we discussed on today's show page at fedgovtoday.com. Up next, the secrets to operationalizing your agency's tools. FedGov Today with Francis Rose continues in a moment. Here's Matt Schmidt of ServiceNow on innovation in government from West.
As I said, cloud means multiple different things to multiple different people. AI can mean multiple different things to multiple different people. But way you can parse that data, way you can bring it in for folks to be ingestible, usable, and be able to get out into the things to actually get outcomes that people need and require is huge. And that's the focus you're starting to see, is that shift from the general, this is a really neat concept, to how do we actually use it? And that'll be the key.
For more, go to innovationingov.com. Welcome back. Federal government leaders say the elements of the digital transformations they're undertaking are all tools, pieces of a puzzle. They're looking for solutions to make those pieces work together. Steve Kearney's Global Medical Director at SAS, he tells me operationalizing those pieces will be critical to success.
So, what we see is a lot of people are talking about AI, generative AI, they're talking about analytics. For almost 50 years, we've actually been delivering analytics. And so the importance there is you'll make different decisions. We have people every day that go into environments that if they had different data points and could operationalize those, they'd make different decisions. And so in our federal agencies, we're very proud that they see us as that trusted partner who really delivers, operationalizes it. And so I'll give you a good example. If we're looking at a majority of the documents that come in, PDF documents, right? And so it gets real. It's like, not only do we want to do these advanced analytic initiatives, we want to say, how do we get that information into the hands of individuals who can make decisions? How do we get benefits to our service members? How do we get it to our veterans? How do we get it to our citizens? And so keeping that patient and citizen in the middle, delivering, so if I need to be screened for some type of service and it's all in PDF documents, then that's not an effective use of our government employees' times, of all of our healthcare workers. And so by changing that dynamic, we can have them operate at the top of their license, at the top of the capabilities they have within an agency. But we're talking real time and changing a directive. To give you an example, one initiative looking at just medical bookmarking has improved the workflow by 85,000 hours. That's citizens getting services, that's providers wanting to participate in the program, and that's our leaders saying, wow, these are people we can trust, and they deliver what they say they're going to deliver.
Yeah, and 85,000 hours, that means those employees are doing something of higher value, I imagine.
Much higher
than going through kind of the grinder of paperwork or whatever.
That's right. And look at our workforce challenges. The satisfaction of not only the member and the patient and the citizen, but the satisfaction of the workforce. And so when you say, I have a question, and you actually can electronically go to that question and it's summarized for you, you make a decision. And by the way, many times it's getting to yes instead of getting to no, right? And so analytics can do that for us the best possible way. And then we trust that analytics because we've actually evaluated it, we make it transparent, it's governed. And so everyone throughout the value chain can say, I trust that. This is what we do every day, and you just improved our workflow.
Both DHA and VHA are speaking here at HIMSS and on FedGov Today about their digital transformations. What do you see as the important things to make them successful while keeping that concept that you just described of keeping the citizen, keeping the customer at the center of the operation?
Sure. So, and we have a great relationship with both of those agencies. We've worked with them for a very long time. A lot of times we say, the question you're asking is sitting in a SAS data set. How do we make sure that we operationalize that? So before, we would have folks doing really great work coding and working in, I would say, parts of the organization that not many people knew what they did every day.
Yeah.
Now we have the citizen data scientist that's everyone. So if you're at an executive level, you need to have that information rolled up to you every day so you can have it, whether it's dashboarding or reports, so you can make decisions. And then we have to make it easier, right? Before it used to be, it was SAS and, or another language. But now it's SAS, open source, it's all of our partners working together in one workflow so that then it delivers to those agencies as they're making that transformation. The insights are there, the technology's there, but we have to make it work for the people who work in that space every day. They know it the best. So partnering with them to say, this is the way that we would deliver it after working with you for all of these years is what's important, right? In many instances, we get a lot of point solutions that come in and say, oh, we have a great answer for this one segment. Those don't work very well, right? And so we need to have a view across the entire organization, and then we can make better decisions.
I talked to Steve Kearney at HIMSS 2024 in Orlando this week. You can read more about operationalization on today's show page at fedgovtoday.com. Up next, the digital modernization path ahead for the Defense Health Agency. FedGov Today with Francis Rose continues in a moment. Here's Michelle Wolford on Innovation in Government from West.
A central theme that we're really seeing here today is around data and the importance of managing it, how it's emerging and changing the strategy of the DON. And I would say, a way that industry and military can really enhance the data is making sure that they have the right resources. So that comes with collaborating across industry to see what else is coming up that could be helpful for the mission outcomes.
For more, go to innovationingov.com. Welcome back. Digital modernization strategies are taking hold all across the federal government. Healthcare organizations across the government, like the Defense Health Agency, are drawing from both the government and the commercial sector for solutions. Lieutenant General Talita Crossland is director of DHA. At HIMSS 2024 in Orlando, she tells me what digital modernization means for her agency.
The first aspect of it is how do we bring technology into the healthcare space and use it to help take care of our patients and to make our staff more effectively. But the other thing I think that often gets lost when we talk about modernization is how do we change the model of care and how we deliver care in a way that makes sense to the folks that we are privileged to care for, right? Our patients. And as you all know, our patients span a very broad range of human beings, from the young soldier, sailor, airman, marine that's in the foxhole, all the way back to our healthcare system and in the civilian communities where we're responsible for providing care to 9.5 million beneficiaries. And when you modernize that approach, what does that mean to our customers, if you will, our patients, as well as our own healthcare teammates? And so one of the priorities I have as we modernize our healthcare system is to look at it from a patient-centric driven way. Right? So based on patient experience and actually valuing that, how do we better meet their needs, their healthcare needs, and not just their healthcare needs, their wellness needs? That's the other part of modernization when I say a new model, right? When we look at healthcare in our country, certainly in our healthcare system, we say healthcare together, and we're really talking about what we do to you or for you to make you healthy. I'm now talking about what we do to and for you to make you healthy. But what are the things we can do to keep you healthy? What are the things we can do with your information, your data, to communicate with you, to help you, to empower you, to enable you towards wellness? And so modernization means a lot, not just buying new, cool, neat stuff. We're absolutely doing that. But how do we change the model of care to meet 2023 and what our patients and what our beneficiaries expect from us?
Yeah, the analogy that comes to mind is business process transformation that I hear a lot of agencies talking about in a lot of different contexts. And it's not just how do we digitize this 10-step process, it's rethinking whether we need to do all 10 steps anymore. Is that what you're getting at?
That's exactly right. The way we have embarked on our modernization journey is from the patient perspective. We create personas, and then we look at how they engage our system, and we map all those points out. And anything that we don't think, anything that does not bring value to the patient or the healthcare team, let's put an accent through it, put it back together, and now go, okay, how do we deliver that? And what technologies do we have to help us do that today? And I think our patients not only deserve it, they're going to demand it of us.
One potential challenge of that, I imagine, is there are some folks who get their missions, what they've historically done, X'd out in that process. And I imagine bringing them on board and understanding how you can shift their individual missions is an important part of that process.
Yeah, what a great observation. So what we have right now in medicine is the perfect storm. We don't have enough people throughout the journey to do all the things we want and how we want to do it. Whether there's a shortage of doctors, whether there's a shortage of nurses, whether there's a shortage of technicians and healthcare writ at large, we have a shortage. So it is the perfect storm to redesign the system, because I honestly believe no one loses, right? No one's job is X'd out.
Right.
Really what we're changing is the dynamics and workflow on how to be more effective in the job we all want to deliver, which is to take care of our beneficiaries.
So how is that process changing, manifesting itself throughout your system, ma'am?
Yeah, we actually a movie. So this isn't theoretical. This is a strategy in execution. We've identified 5 locations within our healthcare system. In real time now, we're saying to them, here are these journeys for our patients. These things don't bring value. They decide that, right? The healthcare team and the patients decide, hey, this doesn't bring value. And now we're looking at the technological solution sets, as well as the change management and the behavioral change and the cultural change necessary to actually do it, right? And my part as a director is to look at that and to figure out how we scale it to the rest of the system. So that's how we're going about it. We're starting with 5 venture sites, and they're getting after it as we sit here and speak.
What are they doing, and what do you want to learn from what they're doing to reach that scale that you just described?
Yeah, so one of the things that they're working on, I'll give you one good example. We've said from the pandemic, we learned that virtual care is value added. Value added to our patients, it's safe, it makes care more accessible. I want you to tell me how much of your work you can do virtual. Go back and change your current model to embrace virtual first. What can we do short of bringing the patient in? We will always have ability to bring people in, but most people want us to meet them where they're at when they need it. And so redesign your workflows to do that. And they're doing that. They're saying, okay, well, I'm going to go to 45% virtual. And what does that mean? And that means a lot for the actual healthcare team on how they change their workflows. How do we communicate that to our patients? How do we measure whether that's bringing the value we thought we were going to achieve? So that's what those 5 sites are actually doing right now.
And I imagine one of the values in creating those personas is that you understand what their expectations are, whether they're okay with being virtual or whether they're okay with being virtual for this particular type of consultation, and so on and so on. Am I on the right track there?
You're absolutely on the right track. What the personas are really meant to do is challenge us. In healthcare, we have had the habit of evolving the system based on how the system wants to engage the patient. Personas force us to evolve the system based on who we're here to serve wants to interface with us. Right.
So you talked about a couple of the issues then that didn't have anything to do with technology. You talked about the cultural issues and the change management that goes along with that.
Yes.
Are the techniques that you're using to apply those concepts, to work through those concepts, similar to what people use for other types of change management and other types of cultural change, or are they peculiar to the healthcare provisions sector?
Great question. It is not peculiar. It's leadership. It's understanding people's perspective, understanding, as you mentioned, when you X out things, presumably every dot had a value. It was tied to a human being who believed they were bringing value. How do you lead through that change such that you don't lose that person and the value they bring, and you rebrand that value to bring value in a way that our patients actually need? It's a lot of leadership, and we put a lot of resources against not just saying this leadership, but giving those 5 sites as an example, senior mentors who have run big systems, who understand so that they can talk through. We have partners in industry documenting and getting feedback and helping at the very tactical level those engagements with the nursing staff, with the patients, with the providers to bring about the change we need, to then come up with a playbook. And my big bet is when we do that with 5 sites, we would have learned enough that then when we go to operationalize it across the rest of the organization, we know what are the right levers to pull. Right? We know that this is going to resonate. This is what we need to say. This is how we need to communicate to the community. This is right? And so that's what we're after.
How would you evaluate what you get out of those 5 to determine whether, yes, this is what we wanted to do, we got the results we wanted, and we want to scale this as is, or that we want to tweak it and redirect maybe?
Yes, we certainly have a whole series of measures. And it's funny, as part of moving out on this, I had to untether us from the current measures that drive behavior, which is it's about volume. And as I said earlier in my comments, it's about delivering care, which is volume. I deliver, and it's a transaction that I capture. But it's also about the work that, if I do it here, doesn't generate an appointment. That has value. And so we've got measures on how satisfied our patients are when they don't come see us, how satisfied our patients are when they interact with the automated model that delivers the care that didn't involve us, how satisfied are our providers and our healthcare teams with the tools. So that's just some of the measures. We certainly want to measure where we're spending our dollars and time and resources to get it. And so, yes, we have a whole litany of measures. I think the 2 unique ones that we don't do very well currently is the perceived value from the patient and the healthcare team, because that perceived value is real value, right? It is real value. And if done well, I think we'll put joy back into medicine. I think a little of that's lost.
You can read more about the digital makeover at DHA on today's show page at fedgovtoday.com. FedGov Today continues in just a moment. The new episode of Innovation in Government, presented by Carasoft, recorded on location at West 24 in San Diego, is available on demand. Watch and listen to leaders from the Navy, Coast Guard, Space Command, and the Marine Corps explain how artificial intelligence, cybersecurity, and network modernization are revolutionizing defense strategies and operations. You'll learn more about innovations transforming government and military capabilities. For more information and to watch on demand, visit innovationingov.com. See a vision of the future of national defense. Welcome back. In today's event spotlight, the Shared Services Summit is coming March 21st at the Carasoft Conference Center in Reston. You'll learn about new ideas for shared services that work from government and industry shared services experts. The summit's a collaboration between ACT-IAC and the Shared Services Leadership Coalition. You can read more about it and register at fedgovtoday.com/events. FedGov Today TV returns next Sunday morning at 10:30 with a look at digital transformation at CMS with Andrea Fletcher and Amber Pearson of the VA on that agency's security strategy for the Internet of Things. I'm Francis Rose. I'll see you next Sunday. Thanks very much for watching. Have a great week.